Hello and welcome. Today we'll be discussing a critical complication following heart transplantation, heart transplant rejection. This occurs when the recipient's immune system recognizes the donor heart as foreign and attacks it, potentially leading to severe consequences. Understanding this process is vital for both patients and healthcare professionals involved in cardiac transplantation. The root cause of heart transplant rejection lies in the fundamental principles of immunology. When a donor heart is implanted, the recipient's immune system identifies it as non-self. This is because the human leukocyte antigens, or HLs, present on the donor heart cells differ from the recipient's HLAs. These HLAs are like unique fingerprints that signal friend or foe to the immune system. Even with HLA matching, differences can still trigger an immune response. The recipient's T cells, specifically cytotoxic T lymphocytes, recognize these foreign antigens and initiate an attack to eliminate the perceived threat. The pathophysiology of heart transplant rejection is a complex cascade of immune events. When T cells recognize the foreign HLAs on the donor heart cells, they become activated. Activated T cells release cytokines, which are signaling molecules that amplify the immune response. This leads to inflammation and damage to the heart tissue. B cells can also become involved, producing antibodies that bind to the donor heart cells, leading to antibody-mediated rejection. The inflammation and cellular damage can disrupt the heart's normal function, leading to various complications like decreased contractility, arrhythmias, and ultimately heart failure. In the long term, chronic rejection can lead to graft atherosclerosis, a form of coronary artery disease that significantly reduces the lifespan of the transplanted heart. Heart transplant rejection is a relatively common occurrence after transplantation, with the highest risk in the first year. The incidence varies depending on factors such as the level of HLA matching between donor and recipient, the immunosuppression regimen used, and the presence of pre-existing antibodies in the recipient. Acute rejection episodes are more frequent in the early post-transplant period, while chronic rejection develops over months or years. Improved immunosuppressive strategies have decreased the overall incidence and severity of rejection, but it remains a significant challenge in long-term transplant success. Statistics indicate that a significant percentage of heart transplant recipients will experience at least one episode of rejection during their lifetime. The signs and symptoms of heart transplant rejection can be subtle and non-specific, making early detection crucial. Patients may experience fatigue, shortness of breath, fluid retention, and a general feeling of unwellness. Palpitations or an irregular heartbeat can also occur. In some cases, there may be no noticeable symptoms at all, highlighting the importance of routine monitoring. It's important to note that these symptoms can also be caused by other conditions, so a thorough evaluation is necessary to determine the underlying cause. Any new or worsening symptoms in a heart transplant recipient should be promptly reported to their healthcare team. Diagnosing heart transplant rejection involves a combination of clinical evaluation, non-invasive tests, and invasive procedures. Regular electrocardiograms, or ECGs, are used to monitor the heart's electrical activity. Echocardiograms, which use ultrasound to visualize the heart, can assess its structure and function. Blood tests, including cardiac biomarkers, can help detect signs of heart muscle damage. However, the gold standard for diagnosing rejection is an endomyocardial biopsy. This procedure involves taking a small sample of heart tissue through a catheter inserted into a vein. The biopsy sample is then examined under a microscope to identify the presence of immune cells and other signs of rejection. Heart transplant rejection is broadly classified into two main types: acute rejection and chronic rejection. Acute rejection typically occurs within the first year after transplantation and is characterized by a rapid onset of inflammation and cellular damage. It is often reversible with prompt treatment. Chronic rejection, on the other hand, develops gradually over months or years and is characterized by graft atherosclerosis, which is a form of coronary artery disease affecting the transplanted heart. Chronic rejection is more difficult to treat and is a major cause of long-term graft failure. Antibody-mediated rejection can also be categorized separately and can be acute or chronic in nature. The cornerstone of treating and managing heart transplant rejection is immunosuppression. This involves using medications to suppress the recipient's immune system and prevent it from attacking the donor heart. Common immunosuppressant drugs include calcineurin inhibitors, such as cyclosporine and tacrolimus, and T-proliferative agents, such as mycophenolate mofetil and azathioprine, and corticosteroids. Treatment for acute rejection may involve increasing the dose of immunosuppressant drugs or adding additional medications. In cases of antibody-mediated rejection, therapies such as plasmapheresis, which removes antibodies from the blood, and intravenous immunoglobulin, which provides antibodies to modulate the immune response, may be used. Chronic rejection is more challenging to treat, and management focuses on slowing its progression and managing its complications. Preventing heart transplant rejection involves a multifaceted approach. Careful HLA matching between donor and recipient is essential to minimize the risk of rejection. Pre-transplant screening for antibodies against donor HLAs is also important. Adherence to prescribed immunosuppressant medications is crucial, and patients must be educated about the importance of taking their medications as directed. Regular monitoring for signs of rejection is also necessary, including routine biopsies and other tests. Lifestyle modifications, such as a healthy diet and regular exercise, can also help support overall health and immune function. The prognosis for heart transplant recipients has improved significantly over the years, but rejection remains a significant factor affecting long-term survival. With prompt diagnosis and treatment, acute rejection episodes can often be reversed. However, chronic rejection continues to be a major challenge. Recent research focuses on developing more targeted immunosuppressant therapies that minimize side effects while effectively preventing rejection. Studies are also exploring the use of novel biomarkers to detect rejection earlier and more accurately. Gene therapy and cellular therapies are also being investigated as potential future treatments for heart transplant rejection. The ongoing advancements in the field hold promise for improving the long-term outcomes for heart transplant recipients.